Hi, everybody. Thank you all for joining us for this webinar, which is part of our series of presentations that's being delivered on applying evidence in practice as part of the Comorbidity Project, which is funded by the Australian Government Department of Health. My name is Christina Morell. I'm a Senior Research Fellow and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. Along with Erin Madden, who is a Project Officer on the Comorbidity Project, I have the great pleasure of facilitating this webinar, which is being presented by Dr. Alana Fisher. Before we start, I'd like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting, and of course recognise that we are meeting across Australia. The traditional owners of the lands that I'm currently on are the Gadigal and Wangal peoples of the Eora Nation, but I'd also like to pay my respects to other traditional owners of the lands across Australia for everybody else who is here. I'd also like to recognise and acknowledge many people with lived experience in mental illness and substance use, as well as their families and carers, many of whom have very generously contributed to the development of the comorbidity guidelines and our other resources. I know everybody here is probably very well versed in Zoom by now, but just to quickly go over a few things before we get started. So first of all, to let you know that if you're watching this live or a recording later, you're in listen only mode, which means that we can't see or hear you. So I just want to draw your attention to the Q&A and chat buttons on your screen. Please feel free to click on the Q&A button and type in any questions that you have at any time during the presentation today. We will have some time for discussion and we'll go through as many of those as we can. If you have any comments or anything that is not for Alana, please use the chat. If you experience any technical issues during the webinar today, you can contact Zoom support, or you can access the recording of the webinar, which we will be making available, as well as the PDF handouts for the slides from today. They'll both be available to download from the website on your screen there. If you find the Zoom chat distracting, you can have a play around with the settings on your end to disable what messages that you see. And to do this, you'll need to go to the Zoom desktop app. If you have it installed, click on the setting wheel in the top right hand of your screen, and then select chat on the navigation menu. You should be able to change what messages you see by changing push notifications or even having a fiddle around with your do not disturb times. But it might take a little bit of playing around to get the settings right. So I've put the Zoom link to more information on the screen there in case you'd like to follow up on this after the webinar today. And I think Erin will ironically be posting that in the chat. So we have an exciting series of webinars over the next few months, and you can find out more about those and also register for our upcoming webinars at our website. The link to do that is on screen. And thank you so much to those of you who have been giving us suggestions for future webinars in our previous ones. We do ask for any suggestions. If you have any ideas for topics you'd like to see as part of this series, please let us know and we'll see what we can do. And now it's my very great pleasure to introduce Dr. Alana Fisher, who will be presenting on shared decision-making in mental health treatment today. Alana is a research fellow based at Macquarie University's eCentre clinic, where she leads a program of research on the use of shared decision-making and decision support tools to improve consumer uptake of and engagement with digital mental health treatments for depression and anxiety. Alana's research focuses on enhancing our understanding and delivery of mental health care consistent with the best available evidence, as well as individual preferences, goals, and needs. Until quite recently, Alana was based at the University of Sydney, working with the Comorbidity Guidelines team, and we were very sad to lose her to a competitive fellowship to further investigate shared decision-making, which was a fantastic opportunity for her. So I'm very glad that she's able to be here today and tell us more about what she's been up to. And without boring you with any more from me, I'm going to hand over to her to get started. So thank you so much, Alana.
Good afternoon, everyone. My name's Dr. Alana Fisher, and I'm a research fellow at the eCentre clinic, which is a specialist research clinic based at Macquarie University. So today I'll be presenting on the use of shared decision-making in mental health treatment with a specific focus on what clinicians need to know. So just to reiterate some of the key learning objectives for today's webinar, they're to identify the key rationale for and components of shared decision-making in clinical practice, to articulate the potential benefits of shared decision-making for mental health populations, including those with co-occurring alcohol and other drug use conditions, and finally to understand ways of actually facilitating shared decision-making in practice, including via the use of patient decision aids. So to start off with, I just wanted to provide a quick definition of shared decision-making. And this might be described as a process whereby clinicians and their patients or clients, and potentially also others, for example, family or peer workers, work together to make a mutually agreed upon healthcare decision, which is based not only on the best available research and clinical evidence, but also the individual's informed preferences. So really this focuses on some core elements of the shared decision-making process. And that's the fact that both clinicians and patients or clients are active participants, that the final decisions integrate both the clinician and the patient preferences. And finally, that this is a process which involves a two-way exchange of knowledge and expertise. So this slide here just provides an overview of how shared decision making might be thought to differ from other approaches to decision making. So here you can see three of the most prominent approaches to decision making. So I guess traditionally what you might have thought of as paternalistic or clinician-led approaches to decision making. At the other end of the spectrum being very much autonomous or client-led decision making. And then here in the middle, which might be thought of as being within the middle of these two ends, being shared decision making. You then have three prominent stages of decision-making, which are thought of as information exchange, so the sharing of information between the different parties involved in decision-making, deliberation or the consideration of the different available options, and finally deciding on an option to implement, so actually making a decision or making a choice. So if we focus initially on this initial stage, looking at some differences between the different approaches to decision-making, as you can see in both the paternalistic and in the autonomous approaches, the flow of information is largely one way, so from the clinician to the client, whereas in the shared approach, you have a two-way exchange of information. So the clinician providing information to the client, and in turn, the client providing information about their condition and about their life circumstances to the clinician. In terms of the type of information that you might find in these exchanges, you have clinical information, whereas in both the shared and the autonomous approaches, you have both clinical information and also personal information. And in terms of the amount of information that's exchanged within those traditional paternalistic approaches, decision-making, you have just the minimum legally required amount of information. Whereas in both the shared and autonomous approaches, you have all information which is seen to be relevant for making a decision. If we move on next to the deliberation of options, you can see in the traditional paternalistic approaches, you have the clinician deliberating on the options by themselves or working with other clinicians within, say, a multidisciplinary team. Whereas at the opposite end of the spectrum, you have the client deliberating or considering options by themselves, potentially with the help of others, for example, a spouse or another support person. In the shared approach to decision-making, however, you have the clinician and the client working together, potentially with others, again, such as family or a support person to consider the options available. And then finally, in terms of making a choice, in the paternalistic approach, you have the clinician making the choice by themselves. In the autonomous approach, you have the client making the decision themselves, whereas in the shared approach, you have the clinician and the client working together to make an agreed upon decision. So another area that I wanted to touch on, which might be relevant to some of the people attending here today, is comparing and contrasting shared decision-making versus supported decision-making approaches. So I should note that arguably there are actually more similarities between these approaches than there are differences. So both these approaches emphasize self-determination and the importance of making decisions about one's own life. Both recognize inherent power imbalances in psychiatric and other mental health services, and both approaches are premised on the view that the mental health service provider should involve clients and other support people in all relevant decisions. There are, however, some points of differences. So shared decision-making emerged much more in the healthcare setting, so in the provision of treatments and other healthcare interventions, and it's more targeted to decision-making about treatment specifically. Supported decision-making, on the other hand, emerged from disability and human rights, and it encompasses a broader range of decisions. So obviously some of these decisions may focus on healthcare, but they may focus on other areas of the person's life, for example, financial considerations, housing requirements, things like that. And finally, shared decision-making focuses on clients and clinicians arriving at a decision together, whereas supported decision-making holds that people have the right to make own decisions, regardless of what another's perceptions or judgments of their choice are. So an example of this might be refusing treatment. So to give an overview now of some of the essential elements of decision-making, Macquarie and Clayman in 2006 actually did a review of some of the prominent published shared decision-making models at the time to try and extract out what were the common elements and what were perhaps the essential elements to arriving at a shared decision. So the first step, or the first element that they identified, was the clinician actually defining or explaining a problem, whether that be the person's conditions, the symptoms they're experiencing, or the diagnosis that they've just been given. It then involves moving on to the discussion of available options, and also noting here that options may include no change from the current situation or maintaining the status quo. Then moves on to a discussion of the positive and the negative features of the options. So this may include things like the benefits, the associated risks or costs or potential harms of the different options. It then involves actually eliciting from the client their values and their preferences for the different options, which may be something new for them as well. And an additional essential element that these authors identified was actually discussing the patient's ability or self-efficacy to enact options. So it's important not only to discuss their values and their preferences, but also their self-confidence in actually carrying out a particular option. The clinician may then move on to provide their own knowledge and recommendations based on their clinical judgment. Again, check in to clarify the client's understanding of the options that have been discussed, and then go on to actually make a decision or explicitly defer a decision. So this may be an instance where making a decision and making an immediate decision is not necessary, and instead it's actually possible to defer the decision to a later point in time. And finally, also to arrange follow-up. So this may be, again, in a situation where it's not necessary to enact a decision straight away, but rather to return and revisit that discussion at a follow-up appointment. There are also some ideal elements which have been identified in various models of shared decision-making, but perhaps might be seen to enhance the process of shared decision-making, but may not be seen as being essential. And this includes providing unbiased information, so non-directional information about the different options that are available, defining people's roles in decision-making and whether the client actually wishes to be involved in making a decision or whether they wish to largely be informed about the options, but then defer making a final decision to the clinician. Presenting evidence for options and their associated outcomes when this information is available. And finally, coming to a mutual agreement in making a decision. So obviously, what we've discussed so far has been discussing shared decision-making at a rather high level. And then later on, Elwyn and colleagues actually came in and tried to provide a practical step-by-step model on how to implement shared decision-making in practice. And I should note here that Elwyn's background is in general practice. So this is a model that might be seen as being applicable across a number of different client populations and across a number of different conditions. So the first step in this model is called choice talk. And it involves actually introducing to the client an awareness of them having a choice between the available options. And this is in instances particularly where there's at least one viable option or two or more viable options. And many people often don't realize that they have a choice, whereas often this is the case. And I think it's important to note as well that here, it should be recognised that both the clinician and the client have come into this interaction with initial preferences for particular options, and that these preferences may not be informed by a knowledge either of clinical information or a knowledge of information that's relevant to the client. So some example of choice talk, which a clinician may use in an interaction, things like, now that we've identified the issue at hand, it's time to think about what to do next. There's some good information about how these treatments differ that I'd like to discuss with you. Different treatments have different advantages and disadvantages, some which may matter to you more than other people. Treatments aren't always effective and the chances of experiencing side effects vary. Shall I tell you about the options available? And finally, I'm happy to share my views and help you to get to a good decision. But first, may I describe the options in more detail so that you can understand what the decision involves. So the next step in this model is called option talk. And this involves a two-way exchange of information, as I highlighted earlier, between the client and the clinician, and a sharing of knowledge on the available options. So really here, both the clinician and the client are seen as being experts in the room. Obviously the clinician in terms of their clinical judgment and knowledge of the available options and outcomes, and the client in terms of knowledge of their own life and how options are likely to impact on their life, given life circumstances. So some examples for clinicians of option talk might be, have you heard or read about the options for treating or managing? Let me list the options before going into more detail. These options are similar in that these options differ in that with these options, there are some things we need to consider compared to other people. So I want to describe. Can you tell me what you understand about the options we've discussed? So the next stage, and this might be seen as more an ongoing process which takes place between consultations, so outside the interaction between the clinician and the client, is the process of deliberation. And this process may be assisted by the client actually having discussions with people who are important to them. So for example, family members or peer workers. Acting as sounding boards. The clinician may also provide the person with information pamphlets or other decision-making resources like decision aids to aid them in considering the different options. And really here, this is a deliberative process of considering the pros and the cons, so those are the benefits and the costs of the available options, and actually having the client consider what matters most to them in the context of their life and in the context of their condition. So a way of perhaps introducing patient decision aids, for example, which we will discuss more later in this talk, is these tools have been designed to help you to understand your conditions in more detail. So use them and come back so that I can answer your questions. So it might be at this point that you actually arrange a follow-up consultation with your client. So returning to the interaction between the clinician and the client, you then move on to preference and decision talk. And as you can see, the client and the clinician are moving along the continuum from initial preferences to more informed preferences at this point. And this is when both the clinician and the client discuss and check the preferences of everyone to move towards deciding on a best option at that point in time. So some examples of preference or decision talk for clinicians might include what from your point of view matters to you. Are there any concerns that you have at this stage? Do you feel ready to decide at this point? Do you want more time? Do you have any more questions? Are there any things that you'd like to discuss? It's possible we can come back and review things again if you like. And so obviously all those points aren't applicable to every clinical interaction, but they are some pointers to work with. And so the final step in the model is what is known as just simply making a decision. And it's this point that both the clinician and the client should have arrived at more informed preferences with regards to the available options and outcomes. So I have just noted here too that the decision may be to maintain the status quo. So that may be when appropriate, obviously. So doing nothing or no change to what is currently being done, or a watch and wait approach. It may also involve delaying implementing a choice or revisiting a decision later. Or finally, it may involve trialing one option and then reviewing or revisiting that decision at a later set date. And I should also note here that decision-making in this context isn't necessarily to be seen as a linear process, but rather an ongoing and an iterative process. So you may make a decision, trial an option for a period of time, and then actually go back to talking about the options again, and perhaps reviewing these options, considering the pros and cons of these options, and then checking and discussing preferences for these options once again. So as an overall method of having these discussions with clients, it's important that clinicians support their clients in making decisions, and that they may do this by presenting information in manageable chunks, so via a chunk and check approach. And this may be seen as a technique to break down information into smaller and more manageable chunks rather than providing it all at once to the client. And between each of the chunks of information, using methods such as teach back to check for information before moving on to the next chunk of information. And as I've pointed out here, obviously checking that clients understand the information, for example, using the teach back method, which might be seen as a useful way to confirm that the information being provided is actually being understood, and getting people to teach back what is being discussed and what instructions may have been given. So it's important to note too that this is more than just saying, do you understand, but actually checking how well things have been explained and understood. And I think another thing that's important to do throughout these discussions is actually discussing what matters to clients in light of the information that's provided, and checking that their choice is consistent with this, and the fact that this is an ongoing process and that people's preferences may change throughout these interactions as they do become more informed. So as you can see, or as you may be starting to appreciate at this point, shared decision-making is a process that occurs during interactions, but it's important to note too that it doesn't occur in a vacuum. And there are prerequisites for successful shared decision-making, and these involve contributions on the part of a clinician, but also contributions on the part of the client. So obviously thinking that the clinician brings to the table their ability to discuss and communicate evidence and risk effectively, as well as having the requisite knowledge and skills to be able to do this. Clients, on the other hand, contribute their individual characteristics and needs, and also need to have an awareness and ability to communicate their personal preferences and values for the options available. And both of these parties, and any other parties that are involved in the decision-making process, both need to believe in the benefit of shared decision-making, have a willingness to participate, and actually acknowledge that a real choice exists and that current preferences may be at least partially uninformed. So these contributions then really set the scene for the next process, which is quite a dynamic process of communication, collaboration, and activation of the client to participate in these discussions. And finally, coming to informed preferences about the options and arriving at a decision that takes these informed preferences into account. So more recently, there's also been some additional considerations highlighted for the use of shared decision-making in mental health context. And this expanded concept of shared decision-making involves enhancing client engagement. So it acknowledges that there's some additional components beyond simply exchanging information and deliberating on options. And these might include the process of building rapport and mutual trust. It also needs to consider that you may be working with clients with fluctuating mental health symptoms and insight, and that these fluctuations may impact on the person's capacity to make a decision, as well as their self-efficacy to make a decision. So how confident they feel to actually participate in the decision-making process. And finally, also their motivation to engage in the decision-making process. There may also be a more salient role for multiple stakeholders beyond simply the clinician and the client. And this might include family caregivers or peer workers, as I've mentioned before, and as well as the broader social networks that the person has contact with. And finally, there may also be a role for adjunctive motivational interviewing for severe and acute mental health populations. And I know that this has been touched on in a previous webinar. So at this point, you might be asking, why shared decision-making? And I do say that there is a host of imperatives for actually taking part and promoting shared decision-making in your practice. And one of these may be that many healthcare decisions, arguably the majority of healthcare decisions, lack a single best course of action. So for the most part, there are at least two viable options that have similar efficacy and similar evidence of their safety. There's often also, or there may also be limited or mixed evidence to support the superiority of one healthcare option over the others. And there may also be recognition too that different options carry different benefit costs, probabilities, and uncertainties, and that different clients may value these differently. It's important to acknowledge too that there may be an effective or a clearly effective healthcare option, or an option that is actually seen to be clearly superior to other healthcare options, but that it has known adverse side effects, and that these are likely to impact on the client's quality of life and adherence to treatment. Clinicians also have an ethical imperative to ensure that their clients are informed about healthcare options and have the opportunity to be involved in decision-making to the extent that's possible at that time. And finally, most clients want to be actively involved in making decisions about their healthcare, and this appears to be especially so in people that have mental health conditions. And I think it's important to pause here and also think that shared decision-making enables evidence-based, person-centered choices that can optimize their care. And so a way of depicting this visually might actually be seen that shared decision-making is a way of uniting evidence-based care and person-centered communication. There's also a number of benefits associated with shared decision-making in mental health. And a quick review of studies of mental health populations showed that shared decision-making is associated with improvements in how involved people feel in making decisions about treatment, their decisional conflict or decisional delay, clinicians' awareness of preferences of people that are in their care, increased satisfaction with treatment decisions, not only among patients, but also amongst treating clinicians, greater understanding of an individual's own values, more positive attitudes towards mental health recovery, better knowledge about conditions and treatment, which appears to be especially important in the context of chronic health conditions, lessened concern about taking medications, better adherence to medications in the short term, although there is a lack of evidence to show these improvements over the long term. Improvements in the severity of alcohol and other drug use and psychiatric problems in people with AOD use disorders, better uptake of psychoeducational and psychosocial interventions, and better uptake of treatments that are consistent with guidelines, and improvements in the person's self-stigma and help seeking. So as you might appreciate, talking about the requirements of shared decision-making, effective shared decision-making requires a number of complex skills. And these are complex skills not only on the part of the clinician, but also on the part of the client. So the clinician needs to be able to communicate knowledge about treatment benefits and risks in a way that the patient can understand and use. And the client also needs to have an ability to recognize and communicate their needs, values, and preferences regarding treatment, which, as you might imagine, is quite difficult. So patient decision aids are seen as one part of a toolkit to facilitate shared decision-making. They're not necessarily as seen as sufficient for facilitating shared decision-making on their own, but they certainly can promote and enhance this process. And patient decision aids take a number of formats. They can come in the form of a website or a pamphlet. And they provide evidence-based, unbiased information about the available options and outcomes. And they do so in a clear and easy to understand format, which uses not only text-based information, but also graphics. And they also provide what are known as values clarification exercises. And these are used to help clients to deliberately weigh up the pros and cons of the different options against their personal values. Importantly, they can be used before, during, or after speaking with a clinician. And they're designed not to replace discussions with a clinician, but rather to support these discussions, particularly in the area of information exchange and deliberation. And lastly, importantly, to ensure that these resources are of a high quality and are developed in a rigorous manner, they need to be developed in line with international standards, which are known as the ADDAPT criteria. So some important things to note is that you should only use a patient decision aid if it's up to date and reflects evidence-based practice, if it's relevant to that discussion and that decision that needs to be made, if it's relevant to that clinical setting, and if you as a clinician have first familiarized yourself with the content of the decision aid. So there's an online repository of freely available decision aids. And if you find that a relevant decision aid is not available, then I would encourage you to use the shared decision-making elements and steps which were outlined before. For example, choice talk, option talk, and preference or decision talk. And clients may also be encouraged to ask questions in order to promote shared decision-making. So to provide you with a couple of examples, visual examples of patient decision aids which have been developed for mental health, I have this one first, which was developed for the primary care setting to help clients decide on antidepressants. And as you can see, it shows the different options that are available and the relationship between these options and different outcomes. So whether they have a positive or negative impact on outcomes, which might be seen to be important to a client. Another example of a patient decision aid is this one, which was again developed for patients with depression. And here you can see an example of a values clarification exercise. So encouraging people to think about how important the different outcomes might be to them, and then coming to a final decision which integrates actually their preferences for treatment. And finally, here's one that I developed a couple of years ago, which was an online decision aid for people who were deciding on medications and psychological treatment options to maintain wellness in bipolar II disorder. So again, you can see some visual depictions of the effectiveness of options, as well as an example of a values clarification exercise. So some benefits of using a patient decision aid. Well, the most comprehensive systematic review, which incorporated RCTs of patient decision aids across a number of health conditions, found that compared to usual care, Decision aids increase clients' knowledge of their treatment options. They give clients more realistic expectations about the potential risks and benefits of these options. They help clients to make a decision that's more in line with their personal values, help clients to be more involved in the decision-making process, increase their satisfaction with the decision and with the decision-making process itself, help clients to feel better prepared to make a decision, and decrease clients' feelings of decisional conflict. And these relate to feeling uninformed and unclear about personal values. And finally, they also decrease the proportion of clients who are undecided or actually delay making a choice, which in some instances may be problematic. So I also wanted to outline the scope for shared decision-making for clients with co-occurring conditions. So as you know that co-occurring mental health conditions in the context of alcohol and other drug use conditions are frequent, and they often result in more severe presentations and potentially also more complex decisions regarding treatment. So although in the current edition of the guidelines, there's no explicit mention of shared decision-making, there is mention of a number of requirements for shared decision-making, or a number of elements of shared decision-making. So reviewing the chapter on depression and AOD use disorders, for example, it outlines that there's several approaches for treatment which are promising, and further research is needed to establish which are particularly effective. And that clinical evidence should involve the provision of client-centered, evidence-based treatment, which takes into account the client's needs and preferences in a collaborative partnership. And this was also echoed in other chapters of the guidelines. So saying that treatment and care should reflect an individual's needs and preferences while taking into account the evidence base, that there's no clear evidence supporting the use of one treatment over others, and that decisions should be informed by the relevant evidence base in partnership with the client. So I wanted to go through some findings from a systematic review, firstly, which we conducted on shared decision-making for people with problematic alcohol and other drug use and co-occurring mental health conditions. And this was a systematic review which was published late last year. So within this review, we identified 13 relevant articles, and within these included articles, it showed that the vast majority of clients want to be actively involved in decision-making regarding their treatment. And also the interventions designed to support shared decision-making, such as decision aids, are viewed as acceptable, feasible, and useful, not only by clinicians, but also by the clients. Within these included studies, we also found a number of articles which included an RCT or a pre-post pilot trial comparing, for example, a shared decision-making intervention versus usual care, or looking at outcomes before and after using an intervention to promote shared decision-making. And within these trials, we found evidence that using a shared decision-making intervention improves outcomes related to improving the quality of the decision-making. So, for example, increasing people's knowledge and actually there being more agreement between the clinician and the client. There was some mixed evidence, although there was some positive evidence to show that the use of a shared decision-making intervention can actually improve treatment outcomes. And in the context of the Houston trial, this was related to greater uptake of alcohol treatment medications. And finally, although there was limited evidence, we did find some positive evidence to show that using these interventions can result in improved symptoms, not only regarding AOD use, but also mental health symptoms. As a second part, we also conducted a needs assessment, and that was designed to assess the information and decision support needs of people who were experiencing problematic alcohol use and co-occurring depression specifically. And this needs assessment was run with 3 main stakeholder groups, and it included 56 people who self-reported at-risk alcohol use and depression at the same time. It also involves 65 clinicians, and these clinicians came from a variety of professional backgrounds. And lastly, we also recruited 16 family members. And this needs assessment highlighted a number of unmet decision-making support needs where there may need to be an intervention to support decision-making. So some of the decisions which clients indicated as being difficult were whether to focus their treatment on depression or alcohol use or both together, whether to start psychological therapy, whether to start add-on medication for depression, and whether to reduce or rather to abstain from drinking. We also found that these difficult decisions were associated with heightened feelings of decisional conflict. And this involved feeling uninformed about the options available, uncertain about which option to choose, feeling unsupported in the decision-making process, feeling as though they were unable to make a choice, and being more likely to delay making a choice. In terms of preferences for decision-making, you can see that the vast majority wanted to be actively involved in making a decision, either in leading the decision themselves or in taking a shared approach to decision-making. Whereas when we actually asked people, did they experience their preferred level of involvement in decision-making, that the vast majority of people indicated that they did not experience their preferred. About a third of people indicated that they did not experience their preferred level of involvement in decision-making. We also asked these different stakeholder groups to indicate their preferences for future decision support tools to inform their design. And here I'm just going to go through the majority of client-rated preferences for these tools. So in terms of how they would like these delivered, the majority of people rated either one-to-one counselling or the provision of information materials. In terms of the format, most people wanted this to be provided either in the form of a website or downloadable fact sheets. In terms of who should be involved in developing these, most people wanted either professional organisations or specialist mental health organisations to be involved in the development of these resources. In terms of guidance using these resources, most people wanted to have a health professional available to provide some guidance in using resources, but a significant proportion of people also wanted to use these resources by themselves. And this represented a deviation from the other stakeholder groups, so clinicians and family members. In terms of timing as to when these resources should be provided, most wanted them to be provided either when preparing for or between consultations with a clinician, and a much smaller proportion of people wanted to have these resources to be used within consultations. And again, this represented a deviation from the other groups that we surveyed. And finally, in terms of the delivery of these resources, most people wanted these to be provided either during a GP appointment or in an appointment with a counsellor or a psychologist. So using these findings, not only from the systematic review that we conducted, but also from this needs assessment, this was then used to design a new patient decision aid resource, which was known as the ADDAPT, and that's the Alcohol and Depression Decision Aid for Psychological Treatments. And some key features of this is that it's based on the best available evidence for single and dual focus psychological treatment. So you might remember that one of the top rated difficult decisions for these clients was deciding whether to focus treatment on alcohol only, depression only, or these two approaches together. It responds to the decision support preferences and needs of clients. The content and the format of this decision aid was developed in consultation with people with lived experience as well as experienced clinicians. It's designed according to international standards and recommendations for decision aids. And it was also copy edited for low health literacy levels to enhance the readability and usability of information in this resource. So I just wanted to highlight some key elements of this. So this decision aid is meant for people who are 16 years or older, who have mild or moderate symptoms of depression, who indicate that they're drinking to risky or hazardous levels and are also in the process of considering options for treatment using psychological approaches. If we refer back to Elwyn's model of shared decision-making earlier, you can see that the first element of choice talk is represented here. So outlining that there is a choice available, that no single best approach, that there is currently no single best approach to treating depression and at-risk alcohol use. And so therefore it's important to consider the evidence, outlining what the main treatment options are. It then also goes on to option talk, so providing an overview which allows comparisons between the different options available in terms of what does it involve, who might be delivering this treatment, how long might this treatment be expected to go for, things like that. Again, within the realm of option talk, it outlines not only the possible advantages of each of the options, so the benefits of these options, but also the possible disadvantages, so the possible harms or the possible costs of the different advantages of the different options. And these are done in a fairly balanced way. Again, to facilitate option talk, there's a summary of the effectiveness of treatment options, not only for depression, but also in terms of improving risky alcohol use. And this is done through a mix of text, but also easy to understand graphics. And there's also the option here to link out to more information if the person chooses to do so, as well as to download this particular page if someone wishes to take it along to a consultation. There's also here, again, an example of values clarification exercise where the person is asked to rate the importance of the positive and the negative features of different options so that they can arrive at a decision which is reflective of their preferences and of their values. And so after counting up how many of these features they've rated as important or unimportant, the person can see whether they're leaning towards one option or not. So I will say that currently we are seeking feedback on this decision support tool. You may or may not have seen some of these ads popping up on your social media accounts. So we're looking for people who are 18 years or older, who are based in Australia, have access to the internet and have experienced depression and risky alcohol use at the same time. And in addition, they need to be currently considering or having recently considered options for psychological treatment. And in terms of what's involved, it involves actually having access to the booklet, going through it, and then answering a survey, which takes approximately 20 minutes. So some take homes of what I've discussed today is that shared decision making involves a two-way exchange of information, knowledge, and expertise. It involves the shared deliberation of options and a mutually agreed upon decision where possible. It really is the union of evidence-based and person-centered care, and it permits decisions which consider the best available evidence, as well as the client's personal values, preferences, and life circumstances. It's best suited to decisions when there's at least two viable options or when the available options carry different benefits and costs that different clients may value differently. We know that it leads to improvements not only in the quality of the decision-making process, but also in the quality of the decisions that are made. And considering too that it may carry additional considerations in mental health in terms of the need to build rapport and the involvement of the client's broader social networks, and that this process may be facilitated by the use of decision aids. So thank you very much for having me today. I will encourage you to, if either yourself or someone you know has experienced depression and risky alcohol use and is considering their psychological treatment options, to go to this URL here, review the ADDAPT tool, and to provide your feedback. Thank you very much, and I invite questions.
Thank you so much, Alana. That was amazing, as always. And would just like to say that we have had some questions come through, and we do have a little bit of time to go through them. As always, we always seem to be running short of time with these webinars. However, we do, like I said, have a bit of time. So first of all, I'm going to start us off with asking you that you did mention, show a slide where you talked about the ADDAPT study and who it might not, or the ADDAPT decision even who it might not be suitable for. Just wondering if you could talk a little bit about whether there were any instances where shared decision-making approaches might not be suitable or appropriate for, or who they might not be appropriate for. The most articulate way of asking that question.
Yeah, yeah, absolutely. So I think just first of all, I just wanted to clarify that even though I said that it's best suited to decisions that whereby there's at least one or more than one viable option, it can obviously be suited to decisions where there might be sort of a fairly straightforward option, but it's still worthwhile having a deliberative, reflective process with the client to find out what their needs and their preferences are. In terms of situations where it might not be so appropriate would be obviously if the client's experiencing acute symptoms, acute mental health symptoms, they're intoxicated or sort of affected by the use of alcohol or other drugs. They're experiencing psychosis. However, in these instances, it would still be worthwhile having perhaps an outline of, the options that are available. However, obviously that final decision may be deferred to the clinician. There's also the possibility to, particularly in conditions that are episodic and there are periods or long periods of wellness followed by periods of acute symptoms, where you might actually engage the person in a stay well or a well-being plan, and so that there can actually be an element of advanced directives or actually engaging the person in thinking about what their options are if they were to become unwell, and then what their preferences might be in that situation. And then obviously if the person finds themselves in a situation where they can't be engaged properly in decision making, at least you have an awareness and you're able to enact their preferences.
Yeah, right. So, in particular periods of unwellness, perhaps not using those approaches, but then maybe coming back to them at other times.
Yeah, and I know that in interviews that I've had, both with people that have a mental health condition of severe mental illness, for example, when I was doing interviews with people with bipolar disorder, that is also in keeping with people's preferences. So people did have somewhat dynamic preferences. They did acknowledge that there were periods that they could be more engaged in decision making. And then there were other situations where they acknowledged they were more unwell and they were comfortable deferring the decision making to the clinician in those instances.
And in those instances where they're not able to necessarily participate in the decision making, are those times when you would bring in other people to be involved in decision making, like family members, carers, friends, peer workers?
Yeah. Absolutely. So I think that family members are often working behind the scenes in supporting people, and it's often important to engage not only the person but also their family or other support people if those people are available to them. And I think that often the family members do play a really important role in terms of acting as soundboards for those people. And often a lot of the involvement of decision making goes on behind the scenes during those deliberations that occur between consultations.
Yeah, and of course, then if a person is accessing any decision aids before they come and see a clinician, then you don't know what's happening before. All the decision making might be happening before they are, approaching a clinician to start with.
Exactly. Yeah. So I guess in that case, it is important to check the sort of type of information that the person has been accessing as well. And being able to have high quality decision aids at your disposal that you can provide to people to ensure they're getting access to high quality evidence-based information.
Okay. We do have some more questions, and I don't think we'll be able to get through all of these, but I have put Alana's email address on screen there. So if we don't get to your question, I'm sorry, and you can contact you're happy for people to contact you with any follow-up questions, Alana?
Absolutely. Yeah. Feel free to email me on this address.
So first of all, just in terms of the timing around decision aids, I think that you might have addressed this in your talk, but is there a best time of raising decision aids or shared decision making with clients?
Yeah, so I think it is something that can be raised. I mean, in the work that I've done, I've spoken with people who have recently received a diagnosis of a mental health condition, right up to people that have had a condition for many years. And I think that it's important to engage people as early as possible in thinking about decision making. And I think also as well, because a lot of mental health conditions are now regarded as chronic health conditions, that this decision making process is very much an ongoing and an iterative process and a process of trial and error. It's very different from, I guess, situations where shared decision making and decision aids first emerged, which was in the context actually of breast cancer and people considering mastectomies. And so that's obviously a very acute and discrete decision which is made and, obviously can't be reversed, whereas it's really evolved over that time into a much more fluid and ongoing process.
Yeah, and really interesting when you're talking about, them being used in the context of there being a lack of a single best course of action and really patient preferences and needs and family perspectives, all those coming into account and helping guide treatment decisions. So
yeah, absolutely. And I think it's important to recognize that most decisions that people make in their healthcare, I think that BMJ may have even done a review and found out that, the majority of decisions that people encounter in their healthcare are preference sensitive. And so that there is a role for considering people's preferences and ensuring that they're integrated into people's final decisions.
Another question about whether you know of any evidence in relation to eating disorders.
I actually don't, I'm afraid. Obviously, there is a repository of decision aids. It's possible that it has been updated. I mean, I know that there's decision aids for depression and anxiety, and perhaps other conditions that may co-occur with eating disorders. And obviously, I guess there's also a big role too for family members within eating disorders as well. So it may be a case instead of actually enacting those generic steps of shared decision making with those clients.
Okay. Thank you. And we will be putting some links to the repository that you mentioned will be available in the slides that we'll be sending out after the webinar. Thank you. And maybe just finally, I wanted to ask whether you had any preliminary findings available of your ADDAPT tool yet.
Yeah, so I've had a few people come through the trial so far, and we've found that after using that, first of all, it's a tool that people seem to like. So people are endorsing it as an easy to use tool that's helpful in their decision making and actually prepares them to make a decision and engage in a treatment discussion with their clinician, and that it's a tool that they would recommend to people in their situation. It's also shown to improve knowledge of the treatment options and outcomes, so people are more informed in making a decision. And it also appears to actually help with people's decisional conflict, which was something that we touched on earlier in the talk. So helping people to feel clearer about what about what their options are, feeling more informed and better supported in the decision-making process. So fairly consistent with what we've seen to date in the decision aid literature.
It's a beautiful tool, and I encourage everybody who's still with us to go and check it out if you have time. And we've just, before I move on quickly, we've just got a few comments, really valid points. So from a lived experience perspective, somebody who's employed as a New South Wales peer worker, I just wanted to thank you for advocating for shared decision making and that it should be a cornerstone of contemporary mental health care. And in situations where someone is not able to be involved in shared decision making due to acute mental distress, assisted decision making should be promoted when possible. Thank you. Completely agree. So just before we wrap up, because again, running out of time, and I'm sorry if we didn't get to your questions, please feel free to contact Alana with anything that I didn't get to. Just wanted to quickly put the guidelines up that we've mentioned before. If you want to find out more information about these or our other resources, you can do that at our website. And that includes downloading a copy of the guidelines as a PDF or going through to check out our other resources. And just wanted to thank you all again for joining us for this webinar. If you're interested in looking at this recording, registering for our upcoming webinars, or having a look at our previous webinar library, you can do this at the website there. The next webinars are going to be, or the next one is going to be on the 23rd of November, and that will be on multiple behavioural change, followed by one on the 9th of December, and that will be about trauma-informed care. And then stay tuned for 2022, and that we've got one coming up on neurocognition in AOD settings, and that was really exciting that we're able to do that one. But until then, thank you again for joining us, and thank you so much again, Alana. Please, everybody, enjoy the rest of your day and stay safe. Thank you.
Thanks, everyone.
Bye.